Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein. Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Merck KGaA.
This program is presented by Medscape Education Global.
Hello, my name is Heinz Windel. I'm a professor of neurology, and I'm happy to deliver now a education on the topic what lies beneath generalized myasthenia gravis, exploring novel modes of action of emerging therapies. Myasthenia gravis has been an extremely dynamic field, but only the last few years. Before that, we haven't really seen much therapeutic innovation, but the therapeutic innovation in this paradigmatic autoimmune disease is very much dedicated and derived from specific knowledge we have about the pathophysiology. And I'm trying to run you through that, also giving you insights on current unmet needs with the currently approved therapies and giving you a run through modes of action of the emerging therapies together with currently approved ones. So I'm starting with introducing the pathophysiology of GMG, which has been acknowledged very early as one of the first autoimmune diseases to be a B-cell and antibody-dominated, particularly antibody-characterized autoimmune disease. When you look over the pathophysiology, there is a loss of tolerance against the endogenous structure of the acetylcholine receptor at the neuromuscular junction. So what it means is that the body mistakenly identifies the acetylcholine receptor at the neuromuscular junction as a foreign threat. This is the definition of autoimmunity, where tolerance is broken against a body-owned protein or antigenic structure. So let's break down this cascade of errors into three distinct phases. The first phase is the breakdown of tolerance in the thymus and with T cells. So the journey often begins in the thymus. The thymus is the educational school for T cells. And in many patients, the thymus remains in a way hyperactive or contains even tumors, thymomas that are associated with the disease. What you can see on the far left is antigen-presenting cells that show the acetylcholine receptor peptides to naive T cells, which is something like the educational envisaging. The activation trigger then under these influences of stresses, infections, or specific drugs is that those cells that have been educated to be tolerant become autoreactive and intolerant. We do see T cell proliferation. That means these autoreactive T cells secrete cytokines like interleukin 2, which acts as a growth factor, causing then cells to multiply and mature and proliferate. At this stage, they are, if you want to call it, conductors of the autoimmune orchestration. We then come to phase 2. This is the B cell response and antibody production. Once those T cells are primed, they recruit and activate B cells. So it's a paradigm again of a T B cell cooperation. And the B cells then are the primary drivers of the effector phase of the disease. We see a B cell activation, and the autoreactive T cell communicates with B cells. Often, interleukin 6 is the key cytokine. This leads to differentiation, and under the stimulation, B cells transform into so-called plasma cells, and the plasma cells are the antibody factories. And they then secrete antibodies, particularly autoantibodies, as pumps. They pump out high affinity immunoglobulin antibodies, specifically against the acetylcholine receptor in most of the cases, and they are measurable in the bloodstream. Then there is a third phase, which is the crisis at the neuromuscular junction. The autoantibodies travels to the neuromuscular junction where they wreak havoc through three primary mechanisms labeled 1, 2, and 3. As you can see, one is a so-called functional blockade. So the antibody physically sits on the acetylcholine receptor, preventing neurotransmitter acetylcholine from binding. So if the key acetylcholine molecule can't fit the lock, the muscle won't fire. The second mechanism is antigenic modulation, where there is a cross-linking process. The antibodies grab two receptors at once, causing the muscle cell to internalize and degrade the receptors. So you're simply degrading and not having receptors on the surface. And the third mechanism is a complement-mediated damage. That means this is the most destructive element, where the binding of the antibodies activate the complement cascade, specifically via a element of the complement cascade, which is called C5 and the so-called membrane attack complex, and that physically dissolves the fold of the postsynaptic membrane, flattening it and permanently reducing its signal efficiency. So it's a process of more irreversible destruction. So let me now briefly overview where we stand in terms of the current treatment strategies for patients with generalized myasthenia. So almost all patients get symptomatic therapy, which is nothing else than enhancing the presence of acetylcholine receptor at the neuromuscular junction, which is a short-lived and, as said, symptomatic intervention. Then we have a very prominent role of corticosteroids that is broadly immunosuppressing, suppressing T cells, B cells, and antibody activity. Then we have non-steroidal immune suppressive drugs that are given to reduce the overall dosages of corticosteroids. And there's different versions of it, azathioprine, mycophenolate, cyclosporin, tacrolimus. And only in the last years, we got drugs that were considered to be taken when there was a difficulty to treat. Sometimes this is called refractory MG. The examples being rituximab, so CD20 depletion, cyclophosphamide, and for refractory disease, the first more modern antibody was eculizumab, a complement inhibiting antibody. Thymectomy still belongs to the treatment concepts because thymectomy, being a thymus affected with thymoma or just the thymus, increases the likelihood to have less myasthenic crisis and need less corticosteroids. And if there is a crisis or a crisis-like exacerbation, the treatment is elimination, quick elimination of antibodies, including the pathogenic antibodies, which is done by plasma exchange or immunoglobulins. So we have a problem. This is not very selective. We have a problem with patients that do not adequately respond. to treatment that do not really achieve the treatment goal of complete remission, which have a higher disease burden. And there is, last but not least, a huge treatment burden. Just think of the short, mid, and long-term side effects of corticosteroids or non-steroidal immune suppressive drugs. We have a number of emerging treatments that can nicely be explained as part of the pathogenesis. And here I run you through those principles. Um, on the one side, the elimination of the pathogenic drivers, namely B cells, including plasma cells, is what is the rationale behind CD20 and CD19 antibodies. CD19 differs because CD19 is also expressed on plasma cells, while CD20 is not. The other is reducing immunoglobulins in a more clever way than washing them out. And that is what is behind so-called FcRn inhibition. FcRn is a recycling pathway in the cell that prolongs the half-life of immunoglobulins. When you block that, then you shorten the half-life, and then you're achieving an effect that reduces immunoglobulins in general, something by 60 to 80%. We have complement inhibition that I already mentioned that works pretty directly at the neuromuscular junction. And then we have this more unselective immunosuppressants, steroids, methylprednisolone, or calcineurin inhibitors. So when you look at the rationale, the targets are either B cells or B cells plus plasma cells as reducing the factory source. We have IL-6 inhibition to stop this B cell maturation. We have directly, let's say, pathogenic antibody, including targeting strategies, which is plasma exchange or more selectively FcRn modulation. Then we have complement inhibition with the example eculizumab that is directly reducing destruction of the neuromuscular junction. And then we have symptomatic treatment with acetylcholine receptor inhibitors. So what are the mechanisms used for currently approved therapies, and how do they really differ in terms of where in the disturbance of immune regulatory networks would they work? If you look into the realm of maybe uh, the realm of all therapeutic strategies that we are thinking about, and they are in different phases of the development. So um, looking at plasma cells, we have very general inhibitors coming from oncology, things like bortezomib, not approved, but sometimes used in myasthenia. We have an antibody against plasma cells, which is called daratumumab, which is sometimes used to reduce the plasma cell drive and the antibody drive. And we have the directionality against B cells, the core, including plasma cells, which is an antibody called inebilizumab, or it's also the narrative of so-called CAR T cell therapy, chimeric antigen receptor engineered CAR T cells. There is different versions of it, but most of them are directed against the cell population characterized by CD19. We have CD20 principles, mostly known as rituximab and other types of CD20 directing antibodies. We then have also immune depleting and repopulating principles that work closer towards T and B cell reduction, which is called cladribine, a immune depleting principle that causes a long-lasting T and B cell depletion. And then we have more cytokine modulation and antigen specific or antigen unspecific B cell activity modulation. One is IL-6 receptor and the other is anti-CD40. And coming to the right side, then more on the central role of T-B cell cooperation. We have also a molecule that is working on the another surface receptor characterizing B cells. It's called BCMA, CAR T cell therapy, or you would call it rather cytokine, B cell specific cytokine modulation with anti-buff. And if you go then more to the downstream mechanisms, then it's more directly antibody mediated and therefore much faster acting. We call those therapies the fast onset immune therapy or rapid onset therapies. And this is the mechanisms that act against the complement system. I already introduced anti-C5. There is more molecules, key molecules in some countries already all approved: eculizumab, ravulizumab, zilucoplan. There is other complement factors, anti-factor D or anti-factor B, iptacopan or vermircopan. And then the other big class of molecules is anti-FcRn. We have now in some countries already 3 different FcRns approved: efgartigimod, roxanolixizumab, nipocalimab. Others are still under development. So this is quite complex and in different phases of clinical trials. But we do have, of course, certain differences. Some of them are simple mode of action difference, but we also have key differences in terms of their velocity of onset, in the administration, in the dosing, but also in monitoring requirements, and certainly also in efficacy in different subgroups of patients associated with the chances of remission, time to achieve the remission, and certainly also safety profiles. So let me explain a couple of those differences in the next slides. So I'm not going very deeply into how symptomatic therapy with pyridostic min works. I'm also not going very deeply in how immunoglobulins and plasma exchange work as the class 1 evidence-based first therapy for treating myasthenic exacerbations. Simply spoken, they reduce the number of antibodies and therefore the pathogenetic drive directly in the crisis. The class of complement inhibitors, they are either given intravenously, eculizumab every 2 weeks or ravulizumab every 8 weeks. They simply reduce very significantly the presence of the membrane attack complex at the neuromuscular junction. And the appealing element of this complement inhibition is that complement activation only happens under pathological condition. Positively spoken, this is then a very selective mechanism that only comes into play when there is something burning in the body and not under homeostatic conditions. On the other hand, you might reduce the defense capacity against certain pathogens, and this is why with eculizumab and ravulizumab you have to vaccinate against meningococci. There's a third molecule which is called zilucoplan, which is a nanocyclic peptide that is given once daily subcutaneous injection, works in the same order of magnitude, has the same safety profile, the same mitigation requirements, but is a different molecule, but it does essentially the same, reducing membrane attack complex. Rituximab is a well-known antibody in the neuroimmunology field. It's an antibody that depletes peripheral B cells and is given every half a year. It does certainly have the appeal of low frequency application, but has the downside of taking a pretty long time until you see the effect. The evidences for rituximab to modify and achieve remissions are anyway not very good. So it takes a lot of time. It's slow acting, and it's probably also not very predictable, but it is the key treatment for a certain subtype of myasthenia gravis, MuSK antibody-mediated disease. As in contrast to acetylcholine receptor, MuSK is mediated by a different class of immunoglobulins, IgG4, and these antibodies do not activate complement, and this means they cannot be treated really with complement inhibition. The FcRn inhibitors, there is several of them now approved. There is a new one, which is called roxanolixizumab, is given as a cyclic subcutaneous pump infusion, which appeals for some patients quite comfortable. And the other FcRn inhibitors are either given in fixed doses like nipocalimab or given in flexible adaptive doses with efgartigimod in so-called cycles, where you have to give it either IV or sub-Q every week for 4 weeks, and then you wait until the patient responds and try to stabilize cell. Cladribine, as I said, is a standout because you only give this oral molecule, which is a cytotoxic molecule we know from the MS field, twice in 2 so-called cycles, year 1 and year 2. And this is currently studied in a phase 3 trial. Very interesting because it's a possibility for immune depletion and repopulation therapy to come in. So how about the monitoring? I mean, we in general would recommend a monitoring that is not a monitoring you do because of a certain therapeutic strategy. You do it anyway because you monitor for the treatment effect, specifically of the new biologicals. We would recommend also a de-risking of the immune therapy, which means that prior to starting biologicals and or certain non-steroidal immune suppressive drugs, you would actually undergo a quite diligent vaccination strategy, including specific vaccinations when you consider complement inhibition. What has changed also over the years is that we are now monitor for certain objective scores. One is the MG-ADL, the other is the QMG. MG-ADL is a patient-reported, physician-assessed, last 7-day accumulating affection by myasthenia gravis. Quantitative myasthenia gravis score is a specific neurological exam specifically developed for the affections of myasthenia gravis. You might have different monitoring expectations and requirements under different therapies. Cladribine, for example, definitely causes a very significant depletion of B cells and T cells. The T cell depletion in the periphery means reduction is very long-standing, and that actually can be expected and has to be monitored, and sometimes also then decides on the reapplication of cladribine in year 2, because if the count is too low, you wouldn't actually redeplete and reduce the immunocompetent relevant signal from CD4s. Let me come to one more point that I go through quickly. I mentioned that not all of those principles work equally well in all different types, and generally separating acetylcholine receptor generalized myasthenia from MuSK myasthenia. For acetylcholine receptor myasthenia, more or less all those principles that I demonstrated are expected to work. For eculizumab, ravulizumab, the complement inhibitors, this has been shown. For the FcRn inhibitors, that has been shown. There is meta-analysis that start to compare even the biologicals, and you would generally say they are all in the same ballpark region of efficacy. On the other hand, things get different when you look at MuSK, and I already explained you why that is, because MuSK is generating pathological IgG4 antibodies in contrast to acetylcholine receptor antibodies being IgG1 and IgG3, or does not activate complement. Therefore, complement inhibition doesn't make sense. FcRn modulation, partly approved, makes sense, but it depends on individual expert recommendations. And usually, MuSK generalized myasthenia is fairly well treatable with rituximab. We will see how CD19 antibody inebilizumab will change the landscape, because it has also been positively tested in a study that has now led to approval of CD19 inebilizumab in myasthenia gravis. And then we have seronegative myasthenia, where there is partly no study data or the expectation that not being able to measure a pathological antibody, the antibody-directed therapies might not work. We have also examples of antibody-lowering strategies working quite okay also in seronegative myasthenia. In general, you can take home that the principles of how you approach seronegative myasthenia in general does not differ from acetylcholine receptor myasthenia gravis. So we think about them in a very similar way, but the approval situation is different from compound to compound. So, um, for example, efgartigimod does have a regulatory approval for acetylcholine receptor antibody positive and MuSK antibody positive DMG, but not for seronegative MG. Let me continue and close with the different considerations of efficacy. Cladribine, we yet don't know. We have not seen the trial results that is currently done, but we have seen a small prospective open label study in 13 difficult to treat myasthenia patients, and a case report that a patient with relapsing remitting MS on cladribine because of MS did develop acetylcholine receptor positive myasthenia gravis while on cladribine, which is, in my opinion, extremely unexpected and counterintuitive. Let me close with one or two sentences on the expectancy of the chances of remission. What we have seen is that the new biologicals, particularly also the benchmark on expectations for the new biological, is really that they change the scores of myasthenia gravis activity of daily living significantly. They partly do that with a relatively fast onset, particularly antibody-directed strategies, C5 inhibition and FcRn modulations. Inebilizumab, the B-cell plasma cell depleting principle, is a bit slower in onset, but also significant. And we see that this can be achieved in a lot of patients, in general, a therapy response, but you can also bring 30 up to 70% into so-called minimal symptom expression. And this is one therapeutic goal: no expression of symptoms or full remission, as opposed to minimal symptom expression, which is also considered a remission. So we don't know really how much the chance of remission with a principle such as cladribine is. From this small open label study, we did see significant clinical improvement in 11 of 13 participants, and more than a 3-point reduction in the myasthenia gravis composite score, also in this 11 of 13 participants. So this is quite promising, but we have to wait for the clinical trial results. A last comment on safety. I already mentioned that the interference with C5 is affecting the immune response of against certain pathogens. And this is the reason why you have to vaccinate against meningococci prior to treatment, or you have to bridge or treat with antibiotics to prevent. We do have, of course, a lot of safety knowledge with rituximab, a B-cell depleting antibody. It's relevant to know that particularly in the elderly population where there is comorbidities, additional corticosteroids, this can be a risk, particularly since you also reduce the responsiveness of the immune system to vaccination. So when you're under CD19, you clearly should have your patient vaccinated, or you have to prevent complications when switching to another principle with respective mitigation measurements. FcRns have, as the C5 inhibitors, a relatively good profile. They are relatively immune neutral. They are just doing a similar thing that you can see with plasma exchange. So you're continuously reducing immunoglobulins, but you're not affecting, let's say, the production of immunoglobulins and the cellular immune arm. Cladribine, we have quite some knowledge from the multiple sclerosis field, where it comes as a monotherapy and shows a surprisingly good safety profile, also with very low affection also of vaccination responses. That means we can expect also maybe a similar thing in myasthenia gravis, where, of course, the patient populations are a bit different, particularly also having older patients. So let me summarize. I ran you through the basic pathobiology of generalized myasthenia and why the pathophysiology and pathoimmunology informs about immune selective treatments. I mentioned the unmet needs that we had and have with currently approved therapies, and I ran you through modes of actions of currently approved, but also a variety of emerging therapies where we yet don't know whether they all will be approved and for what indications they might be particularly helpful, but giving you a interesting run through this dynamic field of myasthenia gravis that indeed has a appeal and capitalizes on a very prototypic immune scenario that you selectively can interfere, mainly with targeting B cells, plasma cells, and T cells, or everything together. Thanks for your attention.
This program was presented by Medscape Education Global.